Good morning. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. We are approaching our 9th year, and we're very, very happy about that. Today, obviously, we are not able to meet all of you in person. And so since the pandemic, we have been hosting online events and will continue to do so until it is safe to do otherwise. We have 3 MPN specialists with us this morning. And one of the reasons why we are doing this different approach to teaching and having a discussion is because we get so many questions from you, the patients and caregivers, that are so important, and sometimes we just can't get to them. And so we're going to hear updates from Dr. Stein, Dr. Jeanne Palmer, and Dr. Aaron Gerds. And I'm going to start with letting each one of them bring us up to date on what's happening at their institution. And then we will segue into questions from you. Make sure you post your questions. I will get them and I will ask them as I receive them. So let's first start with Dr. Brady Stein, who is in Chicago at Northwestern. And thank you so much for joining us this morning, Dr. Stein. And can you please give us an update on what's happening in your world these days?
Sure. Thanks very much for having me. I always appreciate these opportunities. Of course, we all wish we could be together, but this is going to work out just fine. So in terms of what we're doing, you know, a lot of us are just kind of making adjustments. We made a lot of adjustments back in the spring in terms of our clinics. I think we shifted to kind of normal, and then I think we're anticipating shifting back. And I think the biggest adjustments we're making in clinic are telemedicine, and that's become a big part of how we're practicing. I think it's going to be a lasting part of how we practice. I think we just have to find a balance. So I think that's going to be true of my co-panelists and hematologists and physicians all across the country. We're all adjusting, trying to keep our teams and our patients safe. In terms of our research, we're participating in clinical trials, largely for myelofibrosis. We're participating in the study with pacritinib for patients with severe thrombocytopenia. We're participating in the KRT study for patients with myelofibrosis. That's an MDM2 inhibitor. And then we're participating in the study from Constellation Pharmaceuticals with the BET inhibitor, CPI-0610. So we're trying to work through enrollment. It's tricky during a pandemic. But again, adjustments and balance and just being resilient through a difficult time. It's what we're all trying to do. That's largely what we're involved in. Thank you.
Dr. Jeanne Palmer, who is at the Mayo Clinic in Arizona. Jeanne?
Yeah, so I would say I echo similar things as to what Dr. Stein said in terms of how we're practicing. We certainly are employing more telemedicine, which I think is fantastic. We have been able to keep open clinical trials, which is great, and have similar portfolio in terms of what studies that we have open here. But I think the most lasting thing is just, you know, when the fact that I feel a lot safer now than I think I did in April, even though numbers can tend to go up and down. And I think because we've employed such good screening mechanisms and stuff that it really makes it safer for people to come in. I feel safe when I'm rounding in the hospital or when I'm seeing patients in clinic just because of the appropriate screening and masking practices. So really, I think even though we're in the midst of a crazy pandemic, I think we're definitely rising to the challenge. I mean, I'm sure at every institution, rising to the challenge and really trying to make sure we can continue to take care of patients.
And Jeanne, I know you do a lot of work in stem cell transplant and stem cell research. Can you talk a little bit about that?
Yeah, we continue to do a lot of transplants. That's certainly been a challenge, taking care of them in the midst of COVID. But I always try to find silver lining in things, and now at least everyone will be wearing masks during cold and flu season, so they won't get the normal colds and flus either. but you know, I think if people employ the right measures and really take, wear masks, isolate, socially distance, I feel like we can make it through this pandemic, regardless of what you're being treated for or whether you're not being treated for anything.
Dr. Erin Gerds at the Cleveland Clinic, thank you for joining us, and please tell us what's happening at Cleveland Clinic.
Well, thank you so much, Anne. It's a pleasure to be here with you and all the listeners, as well as Jeanne and Brady, some real, wonderful friends and colleagues. Here at the Cleveland Clinic, just like Brady and Jeanne already mentioned, we adjusted, right? So when the pandemic hit, things kind of shuttered for a moment. We didn't know what was going to happen, how to go about things. But really, the amazing part of what has happened here is really the processes involved. And I know Jeanne already talked about that, where we're screening folks, we're masked, we're keeping people distance, and like Jeanne and Brady, I feel safe going to work every day, and patients feel safe coming in. I think people are taking this very seriously within our cancer center, which is excellent. In terms of clinical trials, our entire comprehensive cancer center did have a bit of a shutdown when the pandemic hit. We had 11% of our trials closed temporarily due to the pandemic, but we all but one are open again. So things are really up and running. And in fact, for our comprehensive cancer center, our enrollment is on target to beat last year's. So I think the important message is people still get cancers, people still get MPNs, and they need to be treated. And while we have shifted a lot to telemedicine as a component to take care of people, there are a lot of things we have to do in the clinic. One example, again, is clinical trials, and to get access to those therapies that are not otherwise available. That's really the only way to do it. And like Brady and Jeanne mentioned, we have several trials that are open and looking to enroll patients both in myelofibrosis as well as ET and soon PV. And so we're certainly open and ready to take care of people who need it. Likewise, our transplant was a challenge at first. We did delay a lot of patients who were not so urgent to get transplanted. We could stall for a couple of months with their transplants, particularly autologous transplants. But the funny thing that I always hear from patients during the pandemic is like, we were doing this anyways. We were socially isolating. We were wearing masks. This is like, no, it doesn't affect our lives at all. But that is really translated to a lot of the MPN patients I see too, who are taking this very seriously and distancing and masking and avoiding crowds and being very careful about things. And I think it's translating to their safety. I really do. And so I'm glad to hear that they're doing well.
And one of the things we discussed, and I've heard, there was a huge influx of calls right after the pandemic from our patients. And then that kind of tapered off as things as people were locked down and settled down. But there was a lot of fear surrounding, should I go for a phlebotomy? Should I go for a transfusion? Should I go for a bone marrow biopsy? And what would you say to those patients now as the numbers are ticking up, exponentially across the country? What would you say to those patients as safely as everybody, as safe as you all are being in your institutions? What is the message you would like to tell our patients? Because there is an enormous fear about, well, one of the points I wanted to make was, so we had this huge influx of calls and emails, then it tapered off. And now I've had this week, every single day, calls from new patients and emails from new patients. So there was that 8-month or 6-month period where there weren't a lot of new patients, and now this is kind of, it's kind of going peaking. And that was the case with all of us on an advisory board meeting, that they were getting more messages from new patients. So how would you advise our new patients to go for bone marrow biopsies and such? Brady, do you want to start?
Sure. No, I think it's a really good question. And that was kind of what we all juggled with at the very beginning. But what I would say is that whether it's MPNs or other diseases, I think what we have to try our best to do is adhere to standards of care, standard practices that have been time tested, that have been supported by evidence that we know help patients. Those are the things that we have to try to adhere to, those kind of guidances. So what I would say is, like my co-panelists, I really feel like our institution has been extremely safe. The protocols that are in hospitals and clinics are the best way to say it is safe. You know, for example, if a patient was to come for phlebotomy, they have to have a COVID test before, and then once the test is resulted negative, only then can they schedule. There's no, it just looks very different. There's no one in waiting rooms. Infusion times are staggered. The chairs are very distanced. So, I try to, coming in for labs, there's appointments only, and it's not like there's, 15 people in the waiting room. There may be none. So it's just a very different time. I think that it's safe to come to the doctor's office for procedures and tests that your doctor deems are necessary for you to follow through with. And I think it could be worse, for example, with phlebotomy, if we are very, very liberal and we let the counts climb, and God forbid there was a clotting event, that could have been preventable. So my advice to my patients is to follow through with time-tested standards, to adhere to what we know helps patients. And if you're unsure, if you're worried, just ask us, and we'll try to reassure. There are some things that are going to be more elective. There are some things that have to be done now, and we'll try to work through that with you.
You made a good point about they have to be tested for COVID before coming in to have a bone marrow biopsy. Is that the case at both your institutions, Dr. Gerds and Dr. Palmer?
Yeah, so certainly before a lot of things we get COVID testing. So certainly any inpatient admission, any significant procedure or like that. We are not currently testing all patients coming in for phlebotomies or transfusions, but we are heavily screening them. They have to fill out a screener before they even step foot on campus. They have to, they'll get screened when they hit the door. We got temperature, thermometer, infrared camera things, screening everyone as they come in. We have limited access to the building where you can only enter at a certain point. And so really, the way our cancer center is set up, every room is an individual room, so there are no shared rooms, period. So people can keep their distance. Like Dr. Stein mentioned, there's appointments for labs, so they're not crowded. We actually converted the wig boutique as well as a yoga studio and the art therapy studio into extra lab space and flex space. So if the lab does seem like it's busy, we can flex to these alternate lab sites just to spread things out way more.
Great. Jeanne, anything different at Mayo?
No, pretty much about the same thing. That to say, I mean, we always test patients for COVID before bone marrow biopsies, and our treatment center has sort of a protocol it follows depending on the degree of like the severity of the treatment that they get in terms of how much their immune system will be suppressed. But one thing that I think is kind of interesting as this whole process has evolved is, I think when it initially started, I was being a little bit more liberal with phlebotomy on patients because I was like, well, I don't want you to come in and get exposed. But I think now we know that with the safety measures in place, that it's really, as Brady said, it's critical. I mean, not just for the sake of not having blood clots as a standard, but if they do happen to get COVID, having high blood counts, not having your disease properly managed can certainly exacerbate things. So I think that it really highlights the importance of, continuing our normal care, continuing taking care of patients. And I do really feel like we're learning enough about COVID that we can safely do so in the setting of a cancer center.
So one of the questions we received was, when a vaccine, the first vaccine is approved, how do you feel about our MPN patients or your MPN patients getting that vaccine? I know the consensus that I've heard so far is definitely get a flu shot. If you're an MPN patient, you should definitely get a flu shot. Brady, I'll start with you again. How do you feel about, when the first vaccine is available?
So we're getting a lot of questions, and I mean, with all of the last 8 months, there are many more questions and answers, but what I'll tell my patients is that there would have to be a very, very good reason not to get the vaccine, and that's going to be for all of us. So, I trust the process from the scientists and from the FDA, and they're going to be vetted as would any vaccine. So when one is available to us, we'll know a lot more about inclusion, exclusion, about who will and won't be a candidate. But, a lot of our patients are going to be perhaps a little bit more vulnerable, and so we're going to want to protect them. So I tell my patients is that this is something we hope will be very, it will be something we offer to the overwhelming majority of our patients.
Dr. Gerds?
Yeah, and I'd like to again echo the comments about the flu shot too. It's like voting in Chicago, and Brady knows this. Like, right, you vote early and vote often. So it's same with the flu shot. It's never too soon to get the flu shot. So there's that misconception too. Oh, I'll wait till November, because then you're already well into flu season by the time it kicks in. I would say it's going to be in all likelihood the same with a vaccine for the COVID-19 virus. Is as soon as it's available and you have access to it, I think that's the best time to get it, because it's going to take a while to get protection. It's going to take at least a couple of weeks. I think again, like Brady mentioned, we're trusting the process here. That again, these trials are happening at lightning speed for a vaccine trial, and I think we all realize that. But whenever we want to do something and we put our minds to it, we get it done faster and still get it done well. And I think there's going to be plenty of data, plenty of safety checks to take a look before there's a global recommendation. But I think if it does pass those marks and it gets regulatory approval, and there's guidelines by the CDC and who should get it based on the inclusion criteria of the study, absolutely. If you fit those criteria, I would not hesitate. And again, the sooner the better. The soon as you have access to it, get it, because it's going to take at least a few weeks to kick in.
Jeanne, do you have any
Yeah,
other?
no, I completely agree. I think one of the hardest things about this pandemic has been the incredible influx of information, both true information as well as information that maybe doesn't have as much scientific grounding to it. And I think that's one thing I always stress to people, is that you have to trust the experts on this one. I'm not an expert at COVID-19. That's why I trust people who are infectious disease and epidemiologist specialists, whereas you wouldn't really want them treating your MPN. So we all have our own thing that we study, we excel, and we really make sure that we know the ins and outs of. And so we have to really look to those people to guide us through this, rather than trying to make our own assessments of it.
Okay, so I'm going to jump around here because we got a lot of different questions. But one is, if I skip a day of my medicine, in this case it's Jakafi, do I risk a cytokine storm? Jeanne?
Missing one day probably would not cause a problem, or even several days. It's certainly not a medication that you would want to stop immediately. But I think that if a day or two is missed, now one of the things that I know that I've heard during this pandemic, am I echoing?
Yes, you are.
Okay. Okay. One of the things that I have heard during this pandemic is concerns over medication shortages and people reducing their medications because they want to make sure they preserve what they have, and they do that. And I think that I haven't seen the actuality of those medication shortages. So it is really important to sort of maintain the same dosing, maintain what you're doing with it. But if you happen to miss one day here or there, it probably will not mean that you're going to become incredibly ill. Not that I would recommend doing that, but just in terms of the concern.
Dr. Gerds, do you have anything to add to that?
No, I would agree. The concern over medication shortages has not panned out completely, particularly with the JAK inhibitors. There has been some issues with shortages with anagrelide that I've seen, and I think that's independent of the pandemic. I think it's more of a supplier demand type issue. I would not, if you forget a dose, that's one thing, but I would not stop your JAK inhibitor.
Brady, do you have anything to add?
No, I agree with the points made. Yeah.
Okay. All right. So how is JAK2 positive? Well, we know this, how it's diagnosed, but can ET or PMF evolve into PV? An interesting question. Brady?
Sure. Yeah, I think all can, that's the challenge for us, is they can all look very similar. they can all evolve from one to the next. So it's more common for something like ET or PV to evolve to MF after many, many years. It's less common, but it can happen where ET can evolve to PV. You know, I think it may be controversial if it's really a true evolution or if it's sort of been masked and been there all along. MF going to PV, MF going to ET would be kind of unusual. That'd be much more anecdotal. There was a patient that when I was in fellowship 10 years ago, there was a patient who had like a evolution from MF to PV. But again, that's a completely anecdotal experience. So usually they go in the direction of MF, not usually and not away from it.
Jeanne?
No, I think what Brady said is completely accurate. I think we definitely can see people who we've diagnosed with ET who maybe had iron deficiency for another reason, and as soon as their iron's repleted, all of a sudden we realize, wait, actually this is PV. And I think if we do see evolution from MF to one of the other two myeloproliferative diseases, it is somewhat anecdotal, but it also could be based on the pathology read, because reading the degree of fibrosis present can often be quite a challenge, especially for institutions that aren't used to doing it regularly. So that also can be somewhat misleading.
Yeah, I think those are both excellent explanations. I don't have too much to add on top of that.
Okay. So as far as inflammation is concerned, and of course there's concern with COVID and inflammation, and believe it or not, I've been reading papers on bat research because of COVID and because of SARS, the original SARS. This is a lengthy little question, but based on evidence obtained from clinical observations and experimental and molecular studies, an article by a Danish professor, Hasselbach, suggests that chronic inflammation may be both an initiator and a driver of clonal evolution in patients with MPNs. Do you agree with that, Jeanne?
Well, I definitely think that there's some potential biologic mechanisms that could explain how inflammation can drive clonal evolution. I think when you have inflammation, you do have kind of an ongoing progression and growth of cells, and the more the cells grow, the more likely they can be to mutate. That being said, unfortunately, I think the degree of inflammation, as much as we can try to treat it, is something that is hard to manifest. So I suspect that more reflects the underlying disease progressing rather than a direct impact of inflammation. So for example, if you said, oh, well, if I suppress inflammation, my disease won't clonally evolve, I don't think we have evidence of that based on studies with Jakafi, as well as, I certainly wouldn't recommend taking something like steroids or another anti-inflammatory with the concept that it'll prevent evolution.
Yeah, I think there's also epidemiologic evidence too to support the connection between inflammation and clonal, myeloid disorders. So you look particularly within MDS, there's a whole section of literature showing the association of people who have rheumatologic disorders are more likely to develop MDS over time. And so there's clearly a connection between clonality, developing abnormal clones and inflammation. But, I think, and then clearly, MPNs are a disease of inflammation as well, with elevated cytokines and all that stuff. But I think we're just starting to unravel like how interconnected these things are. The paper reference there is a great look at things, but there's still so much unknown about how this association is really connected on a biologic level. But certainly there is some connection there.
Dr. Stein, do you have anything to add to that?
No, I of course agree with the points. I think you're going to find us agreeing with one another a lot. So that's always nice.
That's a good thing.
Yeah, it's a good thing. But and thrombosis is another example. I think there's a lot of hypotheses. These are all hypotheses. Some with more evidence than others, but thrombosis too, might be triggered a lot by inflammation as well. As inflammation, as cytokines are increased, that also there's an interplay with the coagulation system. So inflamed patients may be more at risk for thrombosis. And, obviously we're seeing that with COVID, that there's a lot of papers or theories about COVID as a thromboinflammatory or immunothrombotic type of state. So there are ties between inflammation and thrombosis. But I think what we don't know, just like what Jeanne said, is that we don't know we don't know that anti-inflammatories prevent progression of the disease. We don't know necessarily if anti-inflammatories prevent thrombosis yet.
Well, that's a great segue to my next question, and that is, what are your views on the benefits of an anti-inflammatory diet? And before you answer that, I can tell you I recently had a cancer scare, and it was not cancer, thank God, but the physician recommended an anti-inflammatory diet, which I pretty much adhere to anyway, except I've cut out so many things. Red meat was never really high on my list anyway, but white, sugar, white flour, white everything. And I'm telling you, I feel great. And my blood pressure is normal, completely normal. I'm 64 years old. Everything has gotten better in my world. And so what are your views? Because it seems to me, that it's a great diet anyway, that we probably all should be doing. But for an MPN patient in particular, Dr. Gerds, what are your thoughts about that?
Yeah, I think it's a tough question, right? So you would think, oh boy, this is a disease of inflammation. Inflammation is key. I should go on an anti-inflammatory diet and that will fix things. It's hard, and you think about it on simple levels and more detailed levels. So for example, everything we eat gets processed, right? So it goes in your stomach, it goes into a vat of acid that's more acidic than battery acid and gets broken down. There are enzymes in your body that break down the proteins and the sugars or whatever we consume. So what goes in is not necessarily what's absorbed either. Our bodies pass a lot of things through the system too. So it's hard to say. And it's a lot like doing epidemiologic studies where we're trying to associate an environmental factor with an outcome. There's so many other things that influence that: the duration of exposure, the amount of exposure, other influences that could result in that outcome. There's so many variables and confounders that come into that. The answer is hard to know. There's no clear study paper that has shown that anti-inflammatory diets do lead to better outcomes for patients with MPNs in large prospective studies. A lot of it is driven on how you feel. So certainly I think taking care of yourself is incredibly important, right? A good, well-balanced diet, mindful of your blood pressure, cholesterol, sugar levels, exercising regularly is so important, because if and when your disease needs to get treated with more aggressive therapies, you'll be able to do much better with those therapies because you're taking care of the rest of yourself. So it really is a holistic approach, a whole person approach. I think the link between a diet and what happens specifically with your MPN is really hard to tease out, and we'll probably never, at least in the next several years, get a clear answer on that. But I think it's incredibly important to take care of yourself.
Dr. Stein, would you add anything to that?
No, I think those are all the points that I would make. Patients, I think it's one of the most common questions we'll get, especially a newly diagnosed patient, but a patient who has the diagnosis: what can I do with my diet? Because I think it's about control. Most people, the overwhelming majority who acquired an MPN, it was out of their control. There's nothing they could have done to bring it on or prevent it. And that's very hard for a lot of patients, of course. So all of us are looking for things that we can control to improve an outcome. And so diet often asks, I think the points are really good. Protect yourself, protect your blood vessels, keep a healthy weight, exercise, try to address blood pressure, cholesterol, blood sugar, stop smoking. All those things are really important to, like Aaron said, I think when you need something, you want to be as fit as possible for it. You don't want to be excluded because of another health condition that perhaps had a lifestyle component to it. So I think Aaron's points are all the right points. I don't necessarily recommend one diet over the other. The anti-inflammatory diet always comes up, but I think it's kind of about logic and common sense. and moderation. They don't recommend any types of extremes. And if like you've had a really good outcome from it, if there's incentive for the individual, if you feel a whole lot better, then that goes a long way.
Jeanne, anything to add to that?
No, I think I echo all of those comments. The only additional thing is like it has to be a diet that's sustainable. So a lot of times, people are like, oh, I'm going to go on the keto diet, or I'm going to go on one of these diets that are very, very, well, that are quite extreme, but a lot of them are not sustainable. So I always suggest that, changing diet to go to something like a Mediterranean diet, or, eating less sugar and a lot of that thing, those are just healthy things in general that we all should be doing, not just patients with MPN. And if this is the impetus that makes you do it, that's great, but definitely choose something that's sustainable, because if you choose something that's so hard to achieve and then you're not unable to do so, I think it actually has a real negative effect.
So this is a question we get very often from new patients, and that is how are newly diagnosed patients. So how often should they get a bone marrow biopsy, and what is an indicator of having another one? Let's say they had one a year ago, and what is the indicator for having another one? Jeanne, do you want to start?
Sure. So I think in terms of if the clinical scenario has been unchanged, the frequency in which we do bone marrow biopsies is something that each individual provider kind of has their thoughts on. And I don't think there's a right or a wrong answer there, because I think that there are certainly, it all kind of comes down to, is there something that I can capture on this bone marrow biopsy that I wouldn't be able to otherwise capture? Now, one of the things with MPNs is that the blood really says a lot. So the blood that we can draw out of somebody's vein can be very, very indicative of what's going on in their marrow, whether it be, blood counts increasing, blood counts normalizing, blood counts decreasing. I think, when something clinically changes, it is very important to get a bone marrow biopsy at that time. But on a routine basis, I don't think we truly know. We don't understand completely the clonal evolution and whether we would have a benefit from trying to assess whether their disease is clonally evolving. Even if it is, it's like, what am I going to do different about it? So that's kind of a long-winded way of saying that from a standard point, I think that's a discussion between a patient and their physician. But from the standpoint of a clinical change that's happening, I think it's really important that people get another bone marrow biopsy.
Dr. Gerds?
Yeah, I can completely agree. The way I always explain it to patients is, we live near the well, it used to be the Youngstown factory that made the Chevy Cruze. It's not there anymore, but or Lordstown factory. That I say, like, well, if you're driving down the road and you saw a whole bunch of Chevy Cruzes without doors on them, you would go down to Lordstown, you would check out the factory and say, why aren't you putting doors on these cars? And it's the same thing, right? So if your blood counts are fine, probably things in the factory, your bone marrow are fine. But if we're seeing some abnormalities there that we need more information, like Dr. Palmer said, like we need more information, then we'll go to the bone marrow. So, it's rare that you have a disease where you can sample the tissue of that disease very, very easily. Simple venipuncture, simple blood draw can sample the tissue of the disease on a very basic level. So we can do that whenever to get information. So it definitely obviates the need to get lots and lots of bone marrows. But if there's a question, we want to know what the chromosomes are doing, or something funny is going on, then that can prompt us to do that.
Brady, Dr. Stein?
I really don't have, I agree with the points. I don't have much to add. I think the bone marrow is variably important at diagnosis. Like, you have to have one for a diagnosis of myelofibrosis. For ET, it can help distinguish between that entity and early myelofibrosis, which can look a lot alike. For PV, it's probably more prognostic. That's usually the easiest one for us to make a diagnosis based on the blood alone. The bone marrow is more prognostic. Unclear if the bone marrow is going to lead to action, a different action in PV, but it can be done. So I think the first bone marrows have a different degree of importance compared to the subsequent. And the subsequent were reactive. If nothing is changing, I don't see a reason to do it. If something is changing, like my colleagues have said, and if we are worried that something is that there's a progression or a change that we may act upon, then that's the time to have the next one.
Okay. So there are some questions here about the risks of taking ruxolitinib or Jakafi. And, you know, now that it's been out there for quite a while, and what are some of the patient-reported outcomes that you're hearing and some of the risks that you're seeing in terms of the side effects? And would you say those are dose-related? Dr. Palmer?
So, you know, I think that, you know, first of all, for the symptom burden for splenomegaly, Jakafi is an incredibly helpful drug, excuse me, to help manage the symptoms of the disease. So, you know, when I have a patient who has any of those symptoms, based on, you know, the total symptom score or has an enlarged spleen, it's something that at least comes up in the conversation. You know, I do think that, you know, some of the side effects that I've seen that are particularly bothersome are weight gain is one of them. Like I used to think it was just, oh, okay, well, they're normalizing their weight to where they would have been, you know, before they started to lose weight because of their disease. But I think it actually goes a little bit beyond that. And then there's some biologic basis of that, and it does something to the leptin in the brain, which is involved in weight control. So I definitely see that. You also can see an elevated cholesterol, which is an important thing to monitor because of the fact that we want to make sure that people are maintaining their cholesterol good to prevent thrombotic events. You know, and the other thing with Jakafi is I think it can be an absolutely amazing drug for some, but it isn't always a drug for everybody. So sometimes people do end up getting some fatigue with it. They get anemia with it. Anemia is one of the big side effects with it. It's one of the things that helps it when you're treating PV, but when you're treating myelofibrosis, the anemia can be quite difficult to manage sometimes. So I think just to kind of summarize, you know, you see some metabolic changes with the cholesterol, you can see weight gain, and then the anemia is something that we definitely see, and it becomes sort of a balancing act of how much JAK inhibition we aim for versus how much anemia the patient has.
Dr. Gerds?
Yeah, I completely agree with those, and that's what we usually discuss with folks when they're about to start ruxolitinib. You know, usually start off with talking about the lowering of the blood counts. Again, in PV, that's kind of part of the goal, but for myelofibrosis, it may really put them in a pickle. And we talk about anemia and thrombocytopenia, low red cell and platelet counts. We also do talk about the weight gain. For some patients, it's a desired side effect, but can go beyond what they weighed before they were diagnosed even. And that's definitely part of it, monitoring cholesterol. And we also talk about, you know, the case reports / hints of viral reactivations such as shingles and hepatitis. So, you know, I'll screen folks for you know, undetected hepatitis infections. And then I encourage, you know, all my patients who are of the age to get the Shingrix shot before or during or immediately after starting ruxolitinib, if we can get it done. That way they're protected against a shingles infection.
Dr. Stein, anything to add to that?
The only other thing, all of those totally agree, skin cancers. So we have seen skin cancers. You know, it seems like they're patients, more of my patients who had skin cancers are patients who've had them before and had been maybe on hydroxyurea before. So I think that the patients seem to be prone, but usually what I recommend, or not usually, always, at least once a year having like your full body skin exam. Most of the patients are doing that anyway because they've already had the non-melanoma type skin cancers. That's another thing that we see in consult about. But the challenge is that if they get the skin cancers, usually we're not going to stop the ruxolitinib because it's usually still helping the patient. So if we had a much better alternative, we might go in that direction, but usually we try to support through it.
Okay, thank you. Dr. Spivak at Johns Hopkins references a study of hydroxyurea versus phlebotomy treatment, which concluded that phlebotomy was more successful in controlling PV versus HU. Let's see, it looks like there might be more to this question. And was not carcinogenic or hallucinogenic. Can you speak to that? Do you know about that paper? So let's look at phlebotomy versus HU, hydroxyurea. Brady, you want to start?
Yeah. So I think what he might be talking about is the polycythemia vera study group. And this is, a study that was done and starting, I believe, in the 1970s. And I think it's bringing up probably one of the more controversial areas of our field about whether or not hydroxyurea can increase the risk of acute leukemia on its own. And I think it's extremely controversial. I think a lot of people in the field don't think that the drug alone can increase the risk of leukemia. I'm one of those. I think that it could potentially increase the risk of leukemia if you're adding it to other chemotherapies. But alone, I think it's hard to prove that that drug increases the risk. These are diseases that spontaneously have a risk. And hydroxyurea has been looked at in a lot of different studies, and I'm not sure there's really statistical proof in the last 15 years. So that's the first part. But what I tell my patients are that, there's not really a study you could conduct or that will be conducted that will entirely disprove it, that disprove the association between hydroxyurea and leukemia. What you would have to have is a large study, thousands of patients in each arm, and one group would have to be treated with hydroxyurea alone. The other could never get it, and you'd have to follow for 10 to 15 years or longer. Those studies they're extraordinarily costly, and they just won't be done. So what we explain to our patients is that we use the drug selectively. That's why we don't give it to all patients upon diagnosis. We have criteria to give it to the patients that we think might benefit. And in this day and age, it's still patients we think have a higher risk of having a vascular event. We think that they'll benefit from the drug more than it'll harm them.
Oh, I completely agree. I think that, I also am in the camp where I don't think hydroxyurea causes acute leukemia. I think that these diseases have that potential. It's been used in sickle cell for decades without seeing that increase in acute leukemia. So I think that probably that risk is related to the fact that polycythemia vera in particular, but all of them have that potential. One of the benefits I see of hydroxyurea, and as Brady said, we often use it in patients who we think have a high risk of thrombosis, is that you end up getting more of a steady state of control of hematocrit versus having the ups and downs that you would get when you have to get recurrent phlebotomies. So I think that can provide a benefit. Plus, then the patients people don't get iron deficient, which can have its own set of negative side effects. So, yeah.
Dr. Gerds?
Yeah, I can, as being the third person here in the rotation, I completely agree with everything everyone said. And Dr. Palmer made the point, you get off the roller coaster, right? So for some patients who's, they really get more symptomatic as their hematocrit gets closer to 45%, and they're going to get that phlebotomy, gets them off the roller coaster where they're sometimes not adequately controlled in terms of their symptoms. The other thing, I think the closest we'll ever get to the study that Dr. Stein proposed about prospectively looking at patients was actually done in ET, where it's a part of what's called the PT1 study, where half the patients with ET got hydroxyurea, half did not. And there was no increased risk of disease progression in those patients. There was no decrease in the risk of progression either to either myelofibrosis or acute leukemia. So there is prospective randomized data for hydroxyurea in ET at least. And with a large number of patients with a decent amount of follow-up, but not the 20, 30 years that would really nail home that point. But I think it's at least a peek at that. And like Dr. Stein mentioned, and Dr. Palmer mentioned, it's been used for sickle cell for many years without increased risk of cancer seen there, or of acute leukemia seen there. So I really am of the camp that it's not going to increase the risk significantly, that patients with more aggressive disease are more likely to progress. And I think that's where we see these kind of reports, these anecdotal reports about the association between hydroxyurea and development of acute leukemia.
I know the Research Foundation is looking at a progression study, and just from your perspectives, what would you say, do we have some numbers, like percentages of people that do progress to AML? I mean, can you all speak to that a little bit if you know, and what that looks like? Dr. Stein?
Yeah, I think that the percentages that I would say in clinic for AML, for PV, probably in the first 15 years, I'd say maybe it's 3 to 5%. I think that maybe slightly lower in ET, and then it's going to be higher in myelofibrosis. It could be upwards of 15% at a shorter interval of time. So the risk is probably different based on the different MPN subtypes. I think there's a dependence of time for some patients. Usually, if a PV patient or ET patient is to develop leukemia, it would be unfortunate, but it would usually occur through MF. So it can be part of the progression. It's very rare, but we will occasionally see it, where a patient can jump from ET or PV directly to AML. It's usually through MF.
Dr. Palmer?
Yeah, I completely agree. I think that the one nice thing that we've learned recently is we've also been able to really better risk stratify patients with some of the new molecular tests and everything that we can do. So we are getting better at predicting this risk. Not that it's an absolute. You can definitely have people who you think, oh, I don't see any of these risk features, and that they do develop it. And the other factor is age too. I think that the older someone is, the more likely there's going to be other mutations that may just be normally happening, that potentially, in addition to their myeloproliferative disease, may push it over towards acute leukemia. That being said, it's very seldom that it happens, in a snap. So I think that living, if I'm talking to somebody about that risk, it's there, but it's something that shouldn't become all consuming, because again, the likelihood is low, and oftentimes we will have something preceding it that gives us a hint that something is changing, and we're getting better at being able to address some of those changes.
Dr. Gerds?
Yeah, I completely agree with all those comments. And I think the additional, the other kind of factor here is that we're getting better at diagnosing MPNs, and I think more and more MPNs are being picked up over time, and that will certainly change these statistics. But those are definitely the numbers I quote, the ones that Dr. Stein mentioned when I'm in clinic. The other kind of piece of evidence that says that we're probably underdiagnosing MPNs, and that would affect the numbers is, in the handful of patients on the leukemia service that I round on, they'll come in with acute leukemia, and then we'll kind of backtrack. We'll look at their bone marrows, and we'll look at the mutation profile, and you wonder if they had some sort of MPN all along that was just never diagnosed because they didn't go to doctors or what have you, and then all of a sudden, boom, it turns into leukemia. So I think those things too can affect the overall look at this when we want to know exactly what the risk is. And so these numbers are hard to come by, and certainly efforts by the MPNRF and other groups that are looking at to more precisely make these predictions and estimations of what happens in populations, I think are very helpful, but they're hard things to pin down too. So these numbers are never going to be perfectly accurate. And the thing that I stress to patients that this is what happens in large groups of people, right? You're a study of one, you're a population of one. It only really matters what happens to you, and let's focus on that and do everything we can to minimize your risk, minimize and make sure we're being very careful about your observation going forward, so that when signs do come up, we don't miss them and we can address things before they're real big problems.
A very good point. Where will ROPEG fit into the scheme of things in treatments? Did I ask that question appropriately? Dr. Gerds, do you want to start?
Yeah. So I think ROPEG can certainly be a very helpful addition to the armamentarium. I think a couple of things to think about is what the label looks like if and when it gets approved here in the United States. I know it's already approved in Europe through the EMA, but is it going to be more of a front line, second line? How's that going to look? So I think that will help determine where it fits in the overall treatment profile for patients with MPNs. I think it's getting harder and harder to prescribe interferons in terms of getting insurance approval and coverage. And if there is a medicine with an indication for MPNs, I think it will be incredibly helpful for that angle. I think there's never been a head-to-head comparison with pegylated interferon or pegasus, if you will. So which one's better? We don't know for sure. We like to think that the ROPEG is better because it's less frequently dosed, perhaps a better side effect profile, more consistent levels in the bloodstream, better pharmacodynamics and pharmacokinetics, but we don't know that for sure. But then again, if it does have a label, we do have the trials in PV. There's an ongoing study in ET, so hopefully that data will fill in the entire picture, and I think it will become a key piece of how we treat patients with ET and PV, for sure.
Dr. Stein?
Yeah, no, all points that I agree with. I think what we'll see with it is that the physicians who are supporters of interferon, it's kind of like preaching to the converted. It'll be another interferon, and I think that it'll be, it'd be easier for us because it's going to be approved. And so with pegylated interferon, we prescribe it, and it's almost always denied. We always have to go through an appeal process. So I think it'll help with logistical issues. So I think for the people who are already supportive of the interferon concept, I think it's kind of like icing on the cake. It's like preaching to the converted. I think the bigger question is, if you have an approved drug for PV, will it catch on with the general community of hematologists or oncologists? That I don't know. I think that'll be really interesting to see. I think the other big question is, will we see a paradigm shift towards earlier interventions? Right now, we're kind of reactive, right? We wait for something, and then if something happens and risk changes, or there's a clinical event or a new symptom, it's only then that we act. That's how MPNs have been treated for the most part for decades. The new drug, we just don't know. But I think the interesting part is whether or not there's going to be a paradigm shift. If you have a drug that's approved for early PV, will people embrace it? That's the bigger question.
Dr. Palmer?
Well, I think that one of the things that I'm hoping that that will happen when it's approved is that perhaps the interferons will get a little bit more of a fair shake. I feel like almost everyone can, I mean, first off, you think of the original interferon, which is a short-acting one given 3 times a week. I mean, I've only given that a handful of times, thankfully, but it's really, really tough on the patient. So if that's your experience with interferon, you're not going to want to give it as a provider. I think even with Pegasus, we still see a number of patients with side effects, although I think far fewer of them have the same degree of side effects. But with Ropeg interferon, we've actually had a study that we've done using it on early myelofibrosis. Well, we actually had a combination of patients with later myelofibrosis and early myelofibrosis. And the patients with early myelofibrosis, I think it provides a couple of potential benefits. I think number one, we do know from a lot of the polycythemia vera data that it does potentially reduce the clonal burden. Now, whether that leads to a better disease outcome or better disease, slower progression of the disease, we don't know, but biologically it makes some sense. And for some patients I see with early myelofibrosis, the idea of actually doing something and having some type of intervention that could potentially lead to downstream or later on benefit is something that I think will be really good. And in my study that I've had on this, I found that patients tolerate it a lot better than even Pegasus. So I think over time, having a drug like Ropeg interferon, number one, I think it's going to take a while to be embraced just because of everyone's historical experience with it. But I think over time, I'm hopeful that it will actually have a real benefit to utilizing or harnessing this therapeutic option for patients, because of the fact that more and more are going to be like, oh, wait a second, this person's an interferon and they're not miserable and they're not, they don't feel as bad. So I'm hopeful that it allows us, but it will take a while to permeate to the community for them to say, okay, I'm going to get over all my preconceptions of interferons that I remember from fellowship or from training, which may not have been the best memories.
Okay. Are you aware of any research on the effectiveness of a daily dose of prednisone to elevate Hg counts in secondary myelofibrosis? Brady?
So prednisone has been used, steroids have been used to treat anemia in myelofibrosis for long periods of time. So anemia and myelofibrosis, I think we probably all agree that there's a lot of room for improvement. A lot of the drugs we're using are pretty old, not very specific. They have side effects. If they're to work, the durability is really in question. The efficacy is in question. So for some patients, steroids can be tried for anemia associated with myelofibrosis. Hormonal therapy like danazol, injections, like an EPO-stimulating agent, immunomodulatory drugs. These are all kind of older drugs. We're all waiting for something better, more selective, more specific that could actually help. So steroids have been used, but they definitely, like with any other condition, have their downsides.
Dr. Gerds?
Yeah, I agree. Steroids are always tricky because you don't want to cause the bone loss and the the weight gain, the fluid retention, the high blood sugars. All these side effects that can come along with steroids can be pretty detrimental over the long haul. But anemia it's a tough one to treat, and we are looking for new agents, that's for sure. And if there certainly is this autoimmune component to the anemia, steroids can be very, very helpful. The question mentioned secondary myelofibrosis. So, I think it's kind of key to separate, well, what is secondary myelofibrosis? So if we're talking like post-PV and ET, that's kind of something different than what is true secondary myelofibrosis from, say, a chronic inflammation, like a chronic infection or autoimmune disorder. So, certainly if it's from one of those causes, treating the underlying issue, whether it's the infection or the autoimmune order for like rheumatoid arthritis or scleroderma or something like that. Now, if you're using steroids to treat the underlying autoimmune disorder and then there's a planned taper and everything, I think that's one thing. Certainly you wouldn't want to do give chronic steroids in case of an infection necessarily, but I think it's important to separating out that as well, because that steroids might be the treatment for the underlying disorder that is causing the fibrosis in the marrow.
Jeanne?
I really don't have much else to add. I completely agree with what my colleague said.
Okay. So what is an optimal range for platelets to avoid an event? Jeanne?
Well, that's a good question. So, platelets are really deceiving because when you look at the normal range is like 150 to 400, depending on the lab. You can get brain surgery if your platelets are above 100. I mean, the neurosurgeons sometimes balk at it, but truly you can get a pretty big surgery if your platelets are above 100. So we know that in terms of what the normal range is and where safe ranges are, you have a difference. You can get a lot of procedures done as long as they're above 50. Spontaneous bleeding is actually below 5 or 10. There's actually some really interesting studies. They were done in the 70s where they took aplastic anemia patients. They took some of their blood out, injected chromium into it, and then they put the blood back in and they measured how much chromium would come out in the stool because just for spontaneous GI bleeds. And it actually looks like 5 is where you really have that risk. But that being said, usually we use 10 as our transfusion parameter, and if they've had any type of bleeding events or anything, it may be 20 or 30. It's a good question because then there's also the question of when do you use anti-platelet agents like aspirin? Where's the cutoff for that? We don't really know, but we do know that it inhibits platelet action. So if somebody has very low platelets, we have to rethink that, as well as anticoagulants, which are both commonly used in patients with MPNs.
Brady?
I totally agree with that. On the flip side, if you're asking about an ET or PV, what's the optimal platelet goal? I don't think anyone knows. I don't think we know that normal protects patients from a clinical event. In fact, the higher the platelet count, the more likely a patient could have bleeding. So the platelet number is a little tricky because if you look at a lot of the studies in ET, the higher the number, the more the bleeding. That's not to say that the platelets don't contribute to blood clotting. It may be more of a quality issue than a quantity issue. But I don't think anyone can say that 400, keeping a platelet count at 400 protects the patient from a clinical event. So yeah, I think it has to be kind of individualized. I think we have a little bit, maybe a little bit better understanding about low numbers, about thresholds for low numbers, when we need to transfuse, when we can do certain procedures. For high numbers, I think it's a little bit different. It sort of depends on your risk of a clotting event, your risk of a bleeding event.
Getting back to the interferon question, we did kind of answer that it's difficult sometimes to get because of insurance. But in the meantime, the patients that cannot tolerate other drugs but do tolerate interferon, in practice, what is the percentage of patients that you see who cannot tolerate Pegasus, just out of curiosity? Dr. Gerds?
Yeah, so I definitely have a handful of patients who just were unable to tolerate Pegasus for whatever reason, whether it was side effects or liver enzymes being elevated, or actually a few patients, they develop cytopenias as a result of the Pegasus, where they become very anemic. You know, it's anecdotal. I didn't sit down and go through my charts and actually give out the number of patients, but I definitely would say probably somewhere in the neighborhood of less than 5% of the patients that I've started Pegasus on, I've had to stop it because of significant side effects.
Dr. Palmer?
I would say depends on the disease type. So there are times with myelofibrosis that I've actually used Pegasus just to potentially aid with this idea of decreasing the clonal burden. And I found myelofibrosis patients have a harder time tolerating it. I think with ET and PV that I agree with Aaron that it's actually a very low percentage that truly can't tolerate it.
Dr. Stein?
No, I agree too. I think probably less tolerance in myelofibrosis. I think those patients have often a larger spleen and might have anemia to begin with, and it's not a drug that really shrinks the spleen if the spleen is more than modestly increased. So I think it depends on the subtype, like Dr. Palmer said. The subtype I use it in the most is polycythemia vera, and to a lesser extent ET. The patients that pursue it, I find that pegylated interferon is usually a medication that patients come to me having already read about, and they want to start it. And so they kind of come in a little bit self-selected. They say, I've read a lot about it, and I'd like you to prescribe it, and if you don't, maybe someone else will. So I think they have, they know, they've read about the side effects, they're prepared for them. Usually it's been younger, lower risk patients, so it's not that we have to treat something right now. We have time, so we have usually an opportunity to start extremely low doses less frequently and then gradually escalate. And I think if you can start slow, start at a low dose and gradually increase, tolerance is generally better. So I think it's different, like the other points made, it's just different than recombinant interferon. And it's different if you have the luxury of time, if you don't have to prevent some consequence right away, but you have a little bit of time to work with the medication, patients usually do better.
You seem to have lost at least the photo or the picture of Dr. Gerds. Are you still with us? Okay, well, why don't I just interject at this point. I do need to thank our sponsors that help make these events possible, albeit online. Insight Corporation, Jeanne, Bristol Myers Squibb, Cartos, CTI, Biopharma, Imago, AbbVie, Pharmacentia, Constellation, and Protagonist. Thank you very much. You help us greatly, and we would not be able to do these without your help. So I love this question because there are so many drugs in clinical trials right now. And the question is, what drug treatments are showing potential in your estimation? I mean, from the papers that I read, there are a handful that I think, just as a person that is not in medical, medically educated, except on my own, that look pretty decent. So, Dr. Palmer, can you share what you see as a possible treatment that is showing potential?
Well, yeah, I agree. This is an incredibly exciting time for, I think, generally myeloid disease or most diseases. I think we're really reaping the benefits of the last 10 to 15 years where we've been able to explore the biologic mechanisms behind them. I think right now the combinations that include ruxolitinib plus another drug are really attractive because there's still symptom control with the ruxolitinib. But then you have several agents. So one of them is the BET inhibitor, which is CPI-0160, has been showing some really amazing benefits. I think another agent that has a lot of promise is navitoclax. The CPI is by Constellation, and navitoclax is an AbbVie agent. And then the third one is there's a class of drugs called PI3 kinase inhibitors, and there's a couple of them that are being studied, one by Insight, and another one, I don't remember the company, but umbralisib is the name of it, and they've both shown some really positive effects. And I think the benefit of this is not only, with ruxolitinib, you're getting a great symptom management, like you can really improve somebody's symptoms and quality of life, but in terms of modifying the disease long term, it doesn't have as much benefit. Whereas some of these agents, I think, really have the potential to help modify the disease moving forward. And I mean, it's going to take a lot more time to really be able to see and quantify that benefit, but I think it's definitely there.
Dr. Stein?
Yeah, and I think I would of course agree with all of that. I mean, we're seeing lots of clinical trials in myelofibrosis, a little less in PV, a little less in ET. So there's lots of clinical trial activity in myelofibrosis, and any of the options that Dr. Palmer mentioned, I think are all with promise. I think myelofibrosis, I think it's a good point that probably that's going to be a disease that will be difficult to really change the natural history of the disease with one drug. Probably going to need to be a combination where with the other subtypes, ET and PV, looking at single agent strategies may be more realistic. So I think any of all of the sponsors that you've mentioned all have clinical trials that are open that are all with promise.
Dr. Gerds, I know we lost you for a moment. The question was, do you see any new drug treatments in clinical trials that are showing potential?
Oh goodness, yes. So yeah, there are a lot of drugs that are coming along that are incredibly promising. I think the key is though making it through that process and evaluating things. I mean, there are phase 1 and phase 2 studies where we get very, very excited about the initial results, and we get up at the podiums at the Annual Society of Hematology meeting or EHA or wherever we are. We talk about how amazing this was in the 15 patients on the study, and it truly was amazing for those patients. But we've been burned before where we look at what are called surrogate markers of outcomes. So instead of like overall survival advantage or remissions, we look at very short interval changes in patients, thinking that may translate to long-term outcomes, and we don't see those results. So we really need to go through the process and do the trials, conduct them, and really see how well these medicines work, and more importantly, make sure they're safe for patients.
Okay, so this patient would like a better understanding of what it means when a patient with MF has a left shift. Does this always mean they're moving toward leukemia? Dr. Gerds, do you want to go first?
So it's not that they didn't have their V8 that day and are like leaning as they walk or anything. The term left shift actually, Dr. Palmer and Dr. Stein might have done this when they were fellows too, but when you look under a microscope and you're counting you're literally counting the cells, and you get this little counter and these buttons all the way across for different subcell types, and as the cells become more immature, you're moving towards the left on this counter. So you're hitting more and more of these keys on the left-hand side of this counter, and that's where the term left shift comes from. You're actually shifting down towards the left on these cell counters. So left shift can be common in patients with certainly myelofibrosis. We see more and more of these immature cells in the bloodstream and in the bone, and potentially in the bone marrow too. The one that we tend to focus on most is the blast, or the most immature cell, and there's definitely associations with that. It's a little bit unclear if increased myelomonocytes or metamyelocytes of these other immature forms have a long-term prognostic outcome, but certainly blasts do. When the blasts are in the peripheral blood or bone marrow, peripheral blood are 10% or more, that's accelerated phase. When they're 20% or more, that's blast phase, akin with acute leukemia. There's emerging data now, at least one paper that we know of, that shows that when the blasts are even above 5%, that's kind of marching towards these more aggressive forms. So it's probably on a continuum. The higher the blasts are, the more aggressive the disease is. But that's, when we're talking about a left shift, that's honestly the one number that has the most data behind it.
Would anyone like to add to that, Brady?
No, I think that's extremely well explained. I think it's really important to know how to look at your blood counts. It's not an easy skill, but I think one that that a patient can gain. And oftentimes, you get a printout, or you might get your blood counts released back to you through a MyChart or a patient portal. And I think it's really a good thing as you're newly diagnosed. And sometimes, newly diagnosed patients, the visits are more educational than they are based on a therapy. We might be doing certain things, but I had a lot of education about the disease. And one thing to try to learn about is how to look at the blood count and try to see what we're seeing, and what is the white blood cell count? Where is that on the report? The hemoglobin, hematocrit, and the platelet count. And then in the differential, trying to look to see what's important. I think I agree. The blasts are probably the most important. The infants, the myelocytes, metamyelocytes, the adolescents, we see them often in myelofibrosis. You can sometimes see them in ET or PV, but that's usually after a decade, or that's usually after a long-standing time with the disease. So I think it's about learning, asking questions like this patient asked about what they're seeing in a report and what it means. It's good to ask.
Jeanne, do you have anything to add to that?
No, those are great explanations. And yes, I too did that little counter thing where you're pressing buttons for a long time. But the only thing I would add is just that, is reassurance that in myelofibrosis, it is normal to see some blasts. We shouldn't see them in a normal person in the peripheral blood, but blasts are a normal part of the growth and the development of it. So in myelofibrosis, we expect to see most of the cells that should normally be in the marrow in the peripheral blood. So if there are a few percentage of blasts are in there, that's a normal thing. It's not something that says, okay, I think you're progressing towards acute leukemia. I think it's more of the change in blasts over time, or if they continue to go up or are higher, where it becomes really more concerning. And I agree. Sitting down, what I sometimes do with patients is actually print out a copy of their CBC in the office, and I say, these are the numbers I look at, because there's a lot of numbers that are outside of the normal range in somebody with myelofibrosis. It doesn't even ding on my radar. So I sort of circle the things and say, this is where I really care about, because otherwise, people come in, they're like, oh my gosh, all of these blood counts have high or low range on them. What's wrong with my blood? And so really making sure that people understand what's important to me if I'm looking at somebody's blood.
We've had some, and first of all, I would like to say that when we hosted an event in Australia, almost every one of those physicians said what Jeanne said, that they, I know time is of the essence whenever you meet with a patient, but that they really encourage them and try to teach them how to read their CBCs, how to, they show them the slides from the bone marrow biopsy and explain what's happening to those that want to know. We know that there are cohorts of patients that sometimes really don't want to know, just treat me and I'll be on my way. And but I think it's a good idea to at least have some explanation, on how to read and what to look for. I recognize that. So this question is something I think we already kind of answered. And some patients with MPNs also have CLL. Is there data on disease progression or best treatment plans for that patient? Dr. Stein?
That's a good question. I don't treat CLL, so I don't know that area well at all. There are associations where patients have myeloid disorders and associated lymphoid disorders, so that association has been written about. I can just say in my own experience, we've seen the MPN has been at the fore, and then we might incidentally find something else, either in the bone marrow, like an aggregate, or something in the peripheral blood. In my own experience, the MPN has been at the fore, or at least that's what I focus on more, just based on comfort level. But the question is, if you had something else that developed that needed to be treated, sometimes it could be the hematologist that treats both. Sometimes you'll need another specialist that's an expert in that area, and the specialist will communicate, and they'll try to look for therapies that don't have overlapping toxicities or side effects that may make the other condition particularly worse.
Dr. Gerds?
Yeah, I completely agree. And the kind of the strategies you pick which one's is the most pressing issue. I definitely had share some patients with our lymphoma docs. One patient comes to mind where they have an indolent lymphoma that needed to be treated, but also had ET that was just kind of hanging out. And actually, the treatment for the lymphoma kind of knocked the ET back for a while, which was kind of convenient. But in that case, the lymphoma was the more pressing issue, need to be treated as opposed to the ET. And I've seen the reverse too. People with a fair number of patients for whatever reason come through lately with MGUS. Along with their MPN, and we, the MPN, as Brady mentioned, is the more kind of pressing issue, so we focus on that as opposed to the MGUS, where we just kind of keep an eye on things. So it really depends on what's the most pressing issue.
Excuse me 1 second. We're hearing some background noise from somewhere, and I can't tell if it's a printer or something's happening. But anyway, I mean, we can still hear you, but there is some background noise coming in from somewhere. Jeanne, do you want to address that question?
Yeah, the only thing I would have to add is that it's very, very common for older patients to have monoclonal B-cell lymphocytosis, which is basically you have a cell that is growing a little bit out of control or abnormally. So you have what we call a clonal population. So a lot of cells that look exactly the same, which we shouldn't see. But when the total count of that white blood cell, that normal white blood cell is less than 5,000, it's what's considered a monoclonal B-cell lymphocytosis, or MBL, which has like 1% per year of transforming into something more concerning. So that is something that we frequently will see in addition to it that really has very, very little additional or prognostic implication.
So there are a couple questions here. One is, have you seen any significance in Jakafi and depression in your patients? I mean, right now it's probably hard to tell because I'm sure a lot of us are a little depressed. But has there been any link that you've seen with your patients on Jakafi? Brady, do you want to start?
Yeah, I have not seen between Jakafi and depression in my patient panel.
Dr. Gerds?
Yeah, certainly a lot of folks struggle with depression and anxiety and related disorders. I'm not aware of any data connecting the two. And I would say in my anecdotal experience in clinic, I've not seen a connection there either.
Jeanne?
Yeah, no, I would agree. I think that there's definitely reports of depression and MPNs in general. And of course, having a chronic disease is a definite stressor. But I don't know that ruxolitinib in particular has been associated with it.
Okay, thank you. Is it possible to misdiagnose a person with sickle beta thalassemia with an MPN? And how similar are those two disorders? Did I pronounce that correctly? Don't worry. Jeanne, do you want to go first?
Yeah, so that's actually kind of interesting. I have a handful of patients who have some type of hemoglobinopathy, which when we talk about a hemoglobinopathy, there's sickle cell 1 thalassemia, and these are where the hemoglobin is abnormally formed, so you don't have appropriately working red blood cells to carry around oxygen. And in the case of a sickle, they're actually shaped like a sickle. They're kind of C-shaped. And then in terms of thalassemia, you just end up getting incredibly small white red blood cells. But I think that the interesting thing is how I have a handful of these patients who have both, like mostly it's been beta thalassemia associated with either myelofibrosis or polycythemia vera, and trying to set where your limits are. So for example, in polycythemia vera, the hematocrit limit I use on this patient is quite a bit lower than I would use in somebody without sickle cell. Without beta thalassemia. And then in terms of figuring out the risk and assessing risk in somebody with myelofibrosis who has an underlying anemia, where do you draw that? How do you assess their hemoglobin in that case? Like, for example, if a normal person, their hemoglobin is less than 10 and they have myelofibrosis, we consider that to be a higher risk disease. Whereas if somebody's baseline hemoglobin is 10, where do you draw that line? So I think that it can be challenging in terms of assessing where our goals of hemoglobin are, but I don't know that I wouldn't say that they're directly related. There's much evidence of that. Although I don't know for sure, but I think it's mostly in just trying to figure out how to gauge where you want the hemoglobin to be in those cases.
Dr. Gerds, do you have anything to add to that?
Not much. I agree. You have to kind of account for both things. You know, and I wouldn't limit it just to hemoglobinopathies either. I have a patient who also has a red cell membrane defect, where you know, the way that the red cell membrane is anchored to itself is defective, and so they have this kind of chronic hemolysis. And so again, it's a challenge. Well, is it because they're inherited, you know, the red cell membrane defect, or is it because of the myelofibrosis and what's really going on? In this particular anecdote, the patient's myelofibrosis risk, independent of the anemia, was high enough to go to transplant, and so kind of fix both problems with one treatment, which is convenient. I'm sure Dr. Palmer will appreciate the transplant angle there, but so it is a challenge, and they can happen in these two problems can happen into one individual, and it makes it a little tricky.
Brady, do you have anything to add to that?
Not much. I think that the overall point, that would probably be pretty rare. I think the overall point is that when counts are high, usually we think about reactive causes or other causes first, or the primary care doctor ought to think more about secondary causes first rather than primary causes, because those are generally more common. So for a high hemoglobin, you know, if the patient's smoking, that's probably a more likely cause than polycythemia vera. But, you know, patients can have what they have, and so you can have secondary and primary causes, right? So we've seen patients who've had splenectomy or their spleen removed for other conditions, and often those patients have high platelet counts. And for many, many years, that might be attributed to just having the surgery, but you can rarely find, and these are more anecdotes, a lot of these cases are much more anecdotal, but you can find that they also have a JAK2 mutation. Maybe because the platelet count went up and up and up over time compared to a prior baseline. In terms of the sickle beta thal question, that's tricky. I think maybe that the patient who's asking this question, with beta thalassemia, the RBC number often increases. That's one of the ways we can recognize it, especially with sickle beta with beta thal trait. So you can have a higher red blood cell number, which maybe could lead someone to think about polycythemia vera, or sometimes patients who have sickle beta thal have had splenectomy, or their spleen is no longer functioning and the platelet count can go up. So the disease, those diseases can sometimes create mimicking situations, but probably more on the anecdotal side. But I think it's just, I guess the point is for us to keep really an open mind, that we like to think about medicine as logical. We like to try to explain based on one diagnosis, but it can often be illogical, and there can be a lot of different things going on that are unrelated. So just to keep an open mind.
Okay, the next question is about transplant, transplant donors. And so it seems that some centers like Johns Hopkins prefer haploidentical donors rather than MUD donors. What are studies showing about relative success rates? And I'll start with Jeanne Palmer.
Yeah, so, you know, I think, so just to kind of briefly review, when we look at donors, there's matched related donors, which are brothers or sisters that are fully matched, and each sibling has a 25% chance of being a full match. There's matched unrelated donors, which is where we go into the large pool of people who are willing to donate their bone marrow, and we generally try to find a 10 out of 10 match, although sometimes we'll take a 9 out of 10 match, and then there's half match. So anyone's child will be half matched for sure, as long as it wasn't donor egg or donor sperm. And then siblings have a 50% chance of being half matched. When we talk about this match, we're talking about HLA markers. So there are 5 HLA markers that we routinely look at that we try to match: A, B, C, D, R, and D, Q, which again is a bunch of alphabet soup that you don't need to remember, but there's 5 and you have 2 sets of them. So that's where we get the 10 that we match. And if somebody is half matched, it'll just be 5 that are matched usually. Sometimes there'll be a couple more depending on the commonality of the different markers. Now, with regards to what type of donor is best, there's been a lot of variability in the data. I think that myelofibrosis in general seems to be more sensitive to mismatches from what we can tell, in that there's some studies that show that match-related donors are superior to even matched unrelated donors, although not all studies confirm that. And then there also does seem to be a difference between 10 out of 10 matched unrelated versus a 9 out of 10 matched unrelated. So, which is greater than what would be expected in another hematologic disorder that would get to bone marrow transplant like myelofibrosis or acute leukemia. Now, in terms of half-matched donors, this is something that over the last probably 5 to 6 years has really become very, very commonplace. There's excellent data coming out that shows that they're equivalent, for the most part, to matched unrelated donors, and potentially even matched related donors because of the ways that we condition people and prevent one of the complications of transplant called graft versus host disease. So in many diseases, I think, whereas haploidentical used to be one of those things where I would say, well, we'd need a study for it. Now I would do it just as standard of care practice. Now in myelofibrosis, we don't have a lot of published data on it. I know that Aaron's been leading a pretty big effort looking at this in a multi-center fashion, using, the handful of haploidentical transplants that have been done at multiple institutions. And I think that over time, I'm very hopeful that this will become a much more commonplace option. I still usually will proceed with a little bit of caution just because of the potential of the mismatch to impact the outcomes. But again, there's not a lot of published data at this point, but hopefully that'll be changing soon, where we'll get a little bit more of a larger cohort with it, at which point I would feel a lot more comfortable. I still will do a haploidentical transplant in the event that I can't find another donor in the right patient, but it's something that I usually hesitate a little bit, not to say that that's the right or the wrong thing to do, but it's more based on my experience.
Dr. Gerds?
Yeah, I completely agree with everything that Dr. Palmer said. So, I think the major take-home points there are, there's to date no data that suggests that haploidentical is better than matched unrelated yet. No head-to-head comparison. There is haploidentical data being developed, as Dr. Palmer mentioned. Well, hopefully we got a presentation at ASH, and then hopefully get the paper out soon. But but the outcomes do look very good. And but the most important thing is everyone has a donor option at this point. Almost, there are very few patients who won't have a donor. So saying, well, gee, I might not have a donor, that doesn't really exist anymore. Between match-related donors, matched unrelated donors, and haploidentical donors, as well as now, as Dr. Palmer mentioned, mismatched unrelated donors. So we are using a single mismatch with post-transplant cyclophosphamide and getting very, very good outcomes from that. So saying, well, gee, I don't have a donor isn't really an option. So if I really do believe that has extended this potential life-saving therapy and potentially curative therapy to a lot of patients who really need it, which I think is the big thing there.
Dr. Stein?
I not much I can add. These are transplant experts, so I can't add to that.
Right. Okay. Well, thank you. That was a great explanations. So what medications, we talked about some that look promising in clinical trials, but which are those that are not JAK-STAT pathway, that are not addressing the JAK-STAT pathway, but other drugs that you see as potentially good for the treatment of polycythemia vera in particular? Dr. Stein?
Yeah, so actually the majority of the on your sponsor list, most of those drugs are non-JAK, are not based on their mechanism of action is not JAK inhibition. So the JAK inhibitors currently that we have, ruxolitinib is approved, fedratinib is approved, and then momelotinib and pacritinib are under investigation. For the other drugs, all the ones that Dr. Palmer and I mentioned, and Dr. Gerds, the clinical trials that we have open are non-JAK inhibitor-based strategies. So the BET inhibitor, the MDM2 inhibitor, PI3 kinase, interferons, all of the LSD1 inhibitors, all of these drugs are not JAK inhibitors. So there's a lot of non-JAK strategies that are being explored.
Okay. Dr. Gerds?
Yeah, absolutely. And I think that's where a lot of us are focusing on now is trying to, JAK-STAT inhibition is incredibly important for the treatment of patients with myeloproliferative neoplasms, but there are clearly other pathways that are activated. And if we can kind of hit it from multiple directions, we can make bigger inroads. Dr. Stein mentioned a lot of the mechanism action. Another one that a couple other drugs that are coming along for PV specifically. There's a drug that works specifically on the hepcidin pathway, which is really interesting. If you ever get up in front of a bunch of hematologists and say the word hepcidin, you get everyone's attention. Hematologists love hepcidin for reasons beyond my knowledge. But so two drugs in particular, this one that's for the treatment of polycythemia vera that's in ongoing trials, and then actually Dr. Stein mentioned momelotinib, and the thought of how that might improve anemia is actually also through hepcidin. So it's really cool because you learn about this stuff in med school, in college science classes, and then you get to use it in the clinic. It's really fascinating.
Dr. Palmer?
No, I don't have much to add to that. I agree the hepcidin mimetic for PB is really a very interesting approach. We have that study open. And then all the things that we're trying to do that are not JAK-STAT related in myelofibrosis, I'm very excited about to see where those are going to go.
I just want to interject also to the listeners that you can post a question. I will see that immediately and try to ask that question right away. So I would be remiss if I didn't talk to the three of you or ask you about your experiences with young MPN patients, because we are hosting a roundtable in December with the parents of children with MPNs, with teenagers and young adults with MPNs. They will be at the table as they have many, many questions. And so just your experience, I see the numbers going up, as more younger people are being diagnosed, and would like to hear what your experience is, as well as treatments. How are you adjusting the treatments for those younger people, especially children? And what is working and what isn't. Dr. Stein, I know you've done a lot of work in this area.
Yeah, I think we are seeing younger patients. I'm an adult hematologist, so I wouldn't see anyone who's usually younger than 18. So I can't really speak about the pediatric experience, but we are seeing younger patients. I think the youngest I've ever seen was about 18. I think the numbers of patients that I have under 25, I can count on my fingers. So it's very, very rare, but it is observed. I think that there's a couple of things. I mean, certainly there can be young patients who are diagnosed like other patients where they are feeling totally well and they have an incidental discovery of an abnormal blood count. So that can happen in the younger population as well. What I see a lot more of, and of course that's what we call a selection bias. At a university you see selected things, you don't see things that are maybe typical. But clotting, we see a lot of patients who present with clots in unusual locations, whether it's the hepatic vein, we call that Budd-Chiari or portal vein. So I see a lot of younger women who are found to have a clot first and then JAK2 later. Sometimes they have high blood counts, sometimes the blood counts are perfectly normal. And a lot of times the early parts of their management, the focus is a lot more on trying to address the blood clot and trying to address the complications of blood clots in those locations, which lead to what we call portal hypertension. So high blood pressure in that vessel district. And these patients are at risk for bleeding, they're at risk for fluid retention. So a lot of the heavy management is with the liver specialist in the beginning. And then, of course, we're weighing in, but usually it's the more acute issues have to do with the portal hypertension. So, the experience can be different. Of course, it can be like that in an adult where it's an incidental discovery, but it can be sometimes more dramatic, and it's often younger women where there's clotting in unusual locations.
So Jeanne, I'm going to change the question a little bit for you. And I know you're not a pediatric hematologist, but I'm curious about, transplant in younger people, so let's not go to children, maybe 18 and older. Do you have many patients that are requesting or seeking, transplant, thinking at a younger age, I'd rather do this now? And I guess I'm saying those patients with MF, but can you talk about that for a moment, please?
Sure. One other thing just to add to the MPN and young people question is actually, before I go to the transplant side of it, is pregnancy. So for younger women who want to have children, there's a lot of, I think sometimes they're told, no, you're never going to be able to have children. And that's probably not true. I think those are the situations where it's really important to seek somebody who really focuses on MPN, because women with MPN can have children. It may be more complicated. There may be more things we have to do, but it definitely is not a contraindication to pregnancy. Recently I've had 3 patients with MPNs who are pregnant all at the same time. And so there's definitely things we're doing slightly differently, but it's certainly possible to have very healthy babies. Now on the side of transplant, that can become very challenging, because you have somebody who's young, they're dealing with a lifelong condition, and even sometimes with PV and ET, they're like, well, just transplant me. I just want to be done with this. And it's always important to, and then part of my job is to explain, look, transplant is great in the right setting, but if it's too early, it's just not worth it, because there is an inherent risk of dying with transplant that's not insignificant, probably around 10 to 15, sometimes even up to 20%. There can be lifelong chronic disease that patients can experience after transplant. So they may be, 25, but then have a chronic condition that will last definitely the rest of their lives, where they might have been able to avoid that condition even for another 15 years. So I think that transplanting for ET and PV is incredibly rare. I don't think I've ever done that. I've only done it in the setting where their PV or ET has progressed to acute leukemia, which is also fairly rare. But then younger patients with MF, I'll watch them a little bit more closely for some of the genetic changes that may convey a higher risk. I will be more likely to bring them to transplant a little bit earlier should I see one of those higher risk mutations, just because of the fact that they are young, and we know that a transplant is definitely going to happen at some point in their future. But again, the timing is very much a shared decision-making process. So there's a certain point before which I will say, no, I do not recommend a transplant. I wouldn't do a transplant. And then there's this kind of a time after which we say, no, you're too far advanced. The likelihood of a transplant being successful is very low. But then there's this large area that's very gray, where it does become a conversation of saying, where are you at in your life? How do you want to do? What are the risks? What are the potential benefits? And trying to establish the right time to proceed with transplant. Another thing to consider in younger people, especially younger women and younger men, is fertility options, and making sure that fertility options are preserved appropriately. It used to be that the way to preserve fertility for women was to harvest their eggs through this whole process where they get very high dose amounts of hormones, which in somebody with an MPN makes me a little anxious, because the fact estrogen is associated with blood clots, and in somebody who has a predisposition, you want to be careful with the amount of estrogen you give. But now there's lots of ways that they can actually harvest eggs in the absence of having to do really high dose hormonal treatments. So the fertility is also something that is important to think about in younger patients when thinking about bone marrow transplant.
Dr. Gerds, do you have anything to add to this?
Yeah, no, those are all excellent points. I really don't have much to add. Whenever a patient is newly diagnosed and certainly has low risk disease, and they ask me, well, let's just transplant this now, I echo a lot of those same sentiments and say, you know what? We've gotten so much better at doing transplantation. The complication rates have come down even in the last 5 years. And if your disease is not going to do anything for 10 years, just think about all the advances in transplant that will be made by that point, if you still need to get it, if we haven't figured out something better for your disease by then. So I think things are always getting better, and you want to find that sweet spot.
A great point. I just want to share, I just got an email from a woman who said that she was diagnosed early in her pregnancy and carried full term and had a normal delivery with a midwife. Bravo to you. And we do host an annual Women in MPN program. We just did a couple weeks ago, actually. So, and there were 8 presenters. So to echo some of the things that Jeanne said, those are discussed at that event as well, and that is online on our website. Moving right along to the next question. Just for clarification, if possible, are MPN patients more at risk of thrombosis if they contract COVID than people without an MPN? Dr. Gerds, do you want to address that first?
Yeah, thank you. I think that's a tricky question. There's just not a lot of data out there yet. It is evolving, that's for sure, and that's really the state of this pandemic. Data is evolving. You know, the way I quite simplistically think about thrombotic risk is everything's additive, right? So if you have an inherited thrombophilia, if you have an MPN, if you have an exposure like immobility or surgery or an infection, you know, each of these things stack up. So it would make sense that the additive effect of having a MPN plus the COVID-19 infection would add up to a higher risk than someone who's identical in every other way, but did not have an MPN.
Brady, do you want to add to that?
I think that's a good way of putting it. That's a really common question that that all of us have been asked over these last 8 months. You know, I think that again, more questions than answers. I'd say the answer is maybe yes, a little, but we don't know. I think what we get asked a lot about are, am I at greater risk for having a severe complication from COVID compared to patients who don't have my disease? And I think it really depends on, you know, your age, what's happened to you with your disease, and the type of disease you have and how you're being treated. So for the younger patient with ET that's never had a thrombotic event, I say that, you know what, the risk may be minimally increased compared to someone your age and gender. For the older ET patient, I might say the same. It might be that your greater risk factor is age more so than the ET itself. In terms of medications, I don't think the hydroxyurea adds to the risk of having a more severe complication. I think theoretically, ruxolitinib, it is an immune suppressive drug, so perhaps there's a greater risk, but at the same time, it's being used in clinical trials to treat COVID-19. So the drug itself probably doesn't, you know, if it's being used as a treatment, not to totally reassure or to sugarcoat, but if it's being used as a treatment, it's probably not. That means that some people believe that there's at least equipoise, that there's potentially more benefits than risks. The transplant population is different, but I think, as said earlier, those patients are probably doing the best job of isolating and distancing and wearing masks compared to anyone. They've been doing this because of their transplants anyway.
Jeanne, do you want to address this?
Yeah, I think, you know, patients, everyone, regardless of whether they're sick or they're not sick, needs to be practicing masking, social distancing, hand washing, all of those types of things, not just for protection of themselves, but for the protection of society in general and other people. You know, with MPNs, I don't think we know. Like, you know, on one hand, even as a transplanter, sometimes I think, well, geez, if somebody's immunosuppressed, maybe, you know, if we think of the problem with COVID, one of the things that's most dangerous about it is the massive inflammation that happens. Well, maybe if you're immunosuppressed, you won't get that same degree of inflammation. We really do not know. You know, there's been a couple of reports published recently that show a very low percentage of patients who have MPNs who actually contract COVID or reported with COVID. And this is a report that was done out of Italy, and then, you know, in a survey that we did, finding very low numbers of patients with COVID. Now, whether it's because they protect themselves better, whether it's because the degree of immunosuppression they have is actually somewhat protective versus harmful to them, I don't think anybody knows. But I think the thing that's the most important is just using all the appropriate measures to keep yourself safe, to keep other people safe. And, you know, and unfortunately, even if with all of that, some people are still going to get it and going to get sick. But what makes somebody really sick with COVID, I still think we're learning. I think it's not as straightforward as, you know, oh, if you're old, you'll definitely get sick, and if you're young, you won't get sick. I think there's a lot of other factors in play that we haven't yet discovered.
Okay, thank you. This patient has been on Pegasus for 5 years, and in remission, however, now has a high ferritin count. Can you speak to that, please, Dr. Gerds?
Yeah, so ferritin is a marker. It can be a marker of a lot of different things. It's sensitive but not specific to things like iron overload or liver injury. So I think the bigger question is, well, why is the ferritin elevated? Is it a side effect of the medication? Is there something else going on that's irritating the liver to cause it to release the ferritin? So I think I think my advice would be to kind of talk with your doctors and say, well, let's dig a little deeper on this and why the ferritin is, because it's usually a sign of something, but nothing in particular often. So you have to kind of do a lot of extra testing to get down to what it is.
Brady, do you have?
Well stated. Yeah.
And Dr. Palmer?
Yeah, no, I think a high ferritin there's so many factors that can contribute to it. So I agree with what Aaron said.
Okay. Is dizziness commonplace from the drug or the JAK2 disease? And MF patients on ruxolitinib who are no longer receiving benefit have heard or read that interrupting treatment for a brief time may restart the benefit. However, none of our doctors are willing to do this in real life. Can you expand on when this might be appropriate and how to do it safely? Dr. Stein?
I think there was a couple of questions in there. One was about dizziness, which can be, you can see that with patients who have ET or PV sometimes can have some dizziness, maybe when the platelet count is really high. So dizziness is a tough symptom, but it's also, there are as many more unrelated causes than there would be related causes, but if everything is ruled out, it's possible it's associated with the high platelet count. Can be a side effect from ruxolitinib. I think I've seen it more when the doses are higher. It seems to be more of a dose-related side effect. I've never had a patient experience such extreme dizziness that they had to stop the drug. And then the last question is more about a difficult one. Can you re-challenge a patient who lost their response to a JAK inhibitor? Is there such a thing as taking a holiday and then having the drug work again? I don't know. I don't know if that, it's not something I've done intentionally. I think we've actually seen it in the clinical trial experience a little bit. Some of the clinical trials earlier on, I think less so now, required long washouts of ruxolitinib. And what we found is that there were patients who we enrolled them in the clinical trial because we were worried they had lost their response to ruxolitinib. But when you stopped it, they started to have rebound symptoms during that washout period, suggesting that maybe it was still doing something. And some of those patients had to go back to ruxolitinib as a part of the trial if they were randomized to a best therapy. So there have been holidays that we've seen in the context of clinical trials where anecdotally some patients have had a little bit of benefit. But I haven't done an intentional holiday to try to reset and then hopefully get the same type of response. I can't say much more.
Dr. Gerds?
Yeah, so I agree with everything that Brady has said, and just to kind of add on to the ruxolitinib retreatment story, we published a small series of patients in collaboration with the folks at USC on this, and really all, as Brady mentioned, it's all out of necessity, right? There is some preclinical data that suggests dose interruptions or pulse treatments may be more beneficial, but it's really just because there have been so many limited, that we're limited in the number of tools we have to treat these diseases. And when, ruxolitinib was the only game in town, and then, now we have fedratinib, but they're both JAK inhibitors. So you try to really squeeze every drop of juice from that lemon when you're making your lemonade, just because there isn't any other citrus fruit to reach for right now. And so, but there are cases where, like Brady mentioned, where patients get interrupted from their ruxolitinib treatment for whatever reason, whether it's going on a clinical trial, whether it's for some sort of adverse event, and then you revisit the ruxolitinib, you can regain responses. But I think in a perfect world, we'll have new and better lines of therapy to follow after JAK inhibitors, or work with JAK inhibitors to make patients' lives better.
And Dr. Palmer?
Yeah, I agree with what's been said. You know, I think one of the things that I've really struggled with is when patients do start to lose their response to ruxolitinib, they get really frustrated and be like, oh, well, I don't want to take this medication anymore. This isn't helping me. And then when they stop it, you do kind of often realize that it is helping more than even if you don't necessarily have the same spleen reduction that would constitute a response or symptom burden, that the benefits that patients can experience off of these JAK inhibitors sometimes will be present even in the absence of meeting these specific criteria. And I think that's also, you know, what we're learning with some of the newer JAK inhibitors that are being studied is that, you know, defining the benefit of a JAK inhibitor is often very challenging because, you know, I have a patient whose spleen didn't change at all, but he felt 80% better than he did previously, even though the MPN symptom score didn't necessarily reflect that either. So I think that, you know, we do often see that loss of response. I have never given anyone a drug holiday, but definitely what Brady said about stopping and then restarting, you can definitely see a return of the response sometimes.
I'm going to ask one more question, and then I would like to, I mean, I knew this would happen. You know, that's why we're going to host these conversations with our experts, because we get so many questions from patients, and I feel so badly when we can't answer all of them in these time frames. But I'll ask one more question and then ask each of you to just kind of give us, you know, any information you'd like to share with all of us. And the question is, I'm 64 with ET and CALR, taking aspirin and hydroxyurea. My mother nearly died at age 80 when she was given aspirin. Should I stop taking it? Believe it or not, it's a question I hear all the time. I'm taking aspirin with my medication, and I'm not real comfortable doing that. Brady, do you want to address that?
Sure. So generally speaking about aspirin, I think the data is the strongest in polycythemia vera, and we have a trial that's now 16 years old showing a reduction in the risk of blood clotting, whether it's affecting the arteries or the veins. So I think we're all pretty comfortable, and we think that it's a really good idea that it's a net positive effect in PV. In ET, it's often used, but I think there's more uncertainty. There's a meta-analysis that pooled like 24 studies and thousands of patients a couple of years ago, and the net effect was really uncertain. It was really unclear if patients had more risks or benefits in ET. So I think it's an unanswered question in ET. It has to be more individualized. Part of it may be, you know, your risk profile, if you have cardiac disease, your symptoms, the type of mutation you have. In MF, who knows? I mean, there are certain patients with MF who have certainly a risk for thrombosis, but there's even less studies in MF than there are in any of the other two, so it's definitely individualized there.
Dr.
Gerds?
Yes, so I think those are all excellent points. And as was mentioned, you really got to focus on the individual patient in these situations. You know, what is your overall risk for blood clot? Is there another indication for aspirin? You know, primary prevention or secondary prevention of strokes or heart attacks, or other reasons. And then, you know, if someone does have a bad outcome while on aspirin, well, do we really think it was the aspirin, or do we think it was something else? So I think on an individual basis, you really got to tease these fine questions apart. But as Dr. Stein mentioned, you know, I think a lot of data in PV that we stand fully behind. ET and MF, it's a bigger question mark of what the value of aspirin may be for large proportions of people.
And Dr. Palmer?
Yeah, I think all excellent points made by my colleagues. I completely agree. I know there's been a lot of concern raised on aspirin in people who are older, but I would say definitely that I wouldn't apply the same concern to someone with myeloproliferative disease. They certainly need to have that as part of the consideration.
Okay. So now I'd just like to, you know, kind of come to a closing here, but with each of you to express whatever you would like to share with us. Dr. Stein?
Well, thank you very much for having me. enjoyed listening to and learning from my colleagues. I think, you know, what can I say? It's always hard to kind of wrap up, but be hopeful. Know there's a tremendous amount of research in your disease. Even the three of us who follow these diseases pretty carefully, we're still overwhelmed by the amount of research. Even us who focus on this every single day, we're overwhelmed, but in a good way because there's a lot changing. So be hopeful for that. Be safe with what we're all going through now, and we're all going to be resilient and get through it. Do the best you can to keep up with your routine medical care. Follow those standards that we know help patients. If you're unsure about whether you should do something or whether you shouldn't, ask your doctor or your nurse. And in general, like you've done with this webinar, when you have questions, ask them. And ask them in between appointments. You don't always have to wait for your appointment if there's something really pressing. The questions that we received, I don't know how many we received, a lot. They were all excellent questions and all questions that you should feel comfortable asking your doctor. And if they don't have the answer, working with a forum that Anne runs, that's a pretty good forum to channel your questions to. So thanks a lot for the opportunity to participate.
Brady. Dr. Gerds?
Yeah, thank you so much. Well put, Brady. I really truly agree that, you know, these are challenging times, and, you know, we're all a little on edge, but certainly if you have questions, concerns, you know, ask your doctor, you know, access forums like this. You know, people often ask too, like, you know, what about second opinions? And I think those are great opportunities just to get more education about your disease. Worst case scenario, you talk to somebody else about what's going on, and they're going to say the same thing. Great, you get that reassurance. It reminds me of the story, you know, being in here in Cleveland, we talk a lot about James Garfield, the president, you know, the president who was from Cleveland, the Cleveland area, and he actually died because of a second opinion was ignored. So really, I truly value the idea of that. And so get your information. I think that's really incredible. This webinar has been fantastic. I always love spending time with all of you. And I think the only thing that we're missing is more of Dr. Palmer's cat.
I'm allergic.
Yeah, well, the cat left the room.
It's not allergy vision, you know. It's just television here, right?
Dr. Palmer?
Yeah, no, I echo everything my colleague said, and thank you again. Thank you very much for having me. I always enjoy these opportunities to see, and honestly, whenever we have one of these meetings or conferences, I learn things too. So just different perspectives. You know, and really echoing with the advent of telemedicine, I think getting a second opinion is actually quite a bit easier and can be of great benefit. So, and you know, personally, if I have a patient and they say I want a second opinion, I said, absolutely, can I help you find somebody? You know, because it's always important for people to get as much information as possible. Nobody should, you know, physicians shouldn't feel threatened by that, and usually don't. And oftentimes really appreciate just having, because these are such rare diseases that, especially if you're in regular practice, I mean, if you have lung cancer and colon cancer and breast cancer patients, I mean, keeping up with that is much more important than keeping up with MPNs because your population of those patients is so much greater. So always making sure that you know, seek out the answers that you need. Coming to these types of forums is an excellent opportunity to learn more. Just because you know, understanding the disease is so important, and making sure that, you know, you feel comfortable with where you're at and don't have to live in as much fear.
Well, thank all of you, the three of you, very, very much. You know how much we appreciate you and respect your opinions and respect your work greatly. And I'm so glad to see your faces. And we will do this again in November. We will host another one toward the end of November, and subsequent conversations like this, because I'm still getting lots of questions right now, and we will address those again. I also would echo that, you know, when I first got into this field, which was in 2004, 2005, there wasn't a lot of sharing of information and lots of conversations, but what I love the most about the people, the physicians that I work with and researchers, not only here, but in the broader, you know, arena of MPNs, is how willing they are to share and how respectful they are to each other. And that's, we could learn from them as a people. And so thank you so very much. I deeply appreciate it. At this time, I would like to also thank our partners who have been tremendous supporters of our work and do have drugs. Many of them have drugs in clinical trials, and those are Insight Corporation, Jeanne, Bristol Myers Squibb, Cartos, CTI Biopharma, Imago, AbbVie, Pharmacentia, Constellation, and Protagonist. I mean, there was a time when nothing like this was happening. So, you know, I'm the old person on the block, and I've seen it all, and there was nothing like this. So I think Brady mentioned, and Dr. Gerds, all of you probably, be hopeful. This is amazing. This is an amazing, we're living through an amazing time, but be hopeful, have that little bit of hope, because there's so much going on in the field of MPNs. Thank you all very much, and have a good day. The sun is shining here. I hope it is where you are.